I know that many of us have addictions. Some of us are addicted to work. Some of us are addicted to coffee. That's me. Some of us are addicted to exercise. But I think addictions, as we know, can be a very, very serious problem. I personally am addicted to this conference because it's like sitting here and just listening to like TED Talks all day long. It's just fantastic. So the panel we have going on in here is Digital Therapies Can Offer a Breakthrough for Treating Addictions. Before I launch into that, I almost forgot. We have a very important person who lost 2 spiral notebooks near one of the front tables. If anyone has found 2 spiral notebooks, it's really important that you bring those to booth 220, which is the Partners Connected Health booth. 2 spiral notebooks. I probably should announce this when we have the whole group here, but look around. If you see 2 spiral notebooks, we do need them back. All right, so digital therapies can offer a breakthrough for treating addictions. And this is going to be moderated, it's going to be a great panel, by Corey McCann, MD, PhD. He's the CEO of Pear Therapeutics. That's a pear. See it. Okay, Pear, it was a lame joke, I understand, but you know, I'm going to put this right here. Okay, there it is. So let me tell you a few things about Corey, because there's some really interesting things. So he is the founder, president, and CEO of Pear Therapeutics, which is an e-health company developing drug and software combination products for diseases of the brain. Previously, he was an investor with MPM Capital. He actually has worked at McKinsey as well. Now listen to this. He led McKinsey's Central Nervous System Expertise Group. So I know a lot of consulting firms. I just didn't know that a firm like one of these firms actually had a Central Nervous System Proficiency Group. It's kind of interesting. All right, and the other interesting thing is that you know, if you think about addiction, it's obviously a brain disorder at some level. And he actually did his PhD years ago. He studied the molecular biology of the most basic building block of neuroscience, which is the synapse. So that's pretty cool as well. So with that, I would like to introduce Corey McCann to introduce the panel from Pear Therapeutics, sorry. Corey, bring him out. Or we'll tell a joke. There we go, okay. Had me sweating up here. I didn't have a joke handy.
Very kind.
All right, take care, guys.
Right. Fantastic. It's great to be here. We were just commenting backstage as to the high production value of these partners conferences. Really, really fantastic to be here. I think for the purposes of about the next hour, what we'd love to talk about are digital applications and digital solutions for addictions. Things like substance use disorder, opiate dependence, many of the issues that are getting a good deal of press right now and also impact a great deal of the American population. I think you're probably all aware of some of the stats, and the folks on the panel can speak to this much, much more articulately. But we're in a position now where about 25 million Americans are impacted by substance use disorder. There's not a day that goes by that we don't hear about someone dying of opiate dependence. And this is an issue which is very, very much at the forefront of the public eye. I personally just learned earlier this week that there are some bad hombres who are in some way responsible for this whole thing. So it's something that lots of us are talking about. It's an area where, very notably, reimbursement is set to get better as opposed to getting worse due to the efforts surrounding the Mental Health Parity and Equity Addiction Act. And what that means is that technology has a great opportunity to plug that gap, to address the unmet need, and to do it in a reimbursed and reimbursable way. And so for the conversation today, what we'd like to do is to really highlight an overview of the solutions that are out there. We have Chris Pesce, who will speak to means of digital engagement in addiction conditions, and Judd Brewer, who will speak to digital therapeutics broadly. And then we're very lucky to have Charlie Curie as well. Charlie was the former head of SAMHSA And we were just having a conversation backstage that I think we have a great sense that these things work, but we have a very poor sense as to how these things are scaled and reimbursed. And so Charlie will help us to think through some issues around scale and reimbursement. So with all of that said, maybe if the folks on the panel can give a brief introduction to who you are, what you do, and then we'd love to dig in from there.
Great.
Please, Chris.
Thanks, Corey. Hi, I'm Chris Pesce. I'm a co-founder and COO of Sober Grid. Sober Grid has built a smartphone app that enables people in recovery from drug and alcohol addiction, or people still struggling with addiction, to connect 24/7 wherever they are for peer support in order to help them both get sober and stay sober, help them prevent relapse. What brought me to my work with Sober Grid was personal experience. I've lost friends and loved ones to the disease of addiction, and that made me take a closer look at the size of this issue. So 45 million Americans are either in recovery or still struggling with addiction. And in fact, things are at epidemic proportions in this country right now. More Americans died from 2014 to 2015 from lethal overdoses than died during the entire course of the Vietnam War. So this really is our generation's epidemic. One of the wonderful things about connected health is that it enables us to put tools and resources to help people combat their addiction and help them to win this battle directly into their hands through their mobile devices. What that's also going to do is enable us moving forward to bring in really interesting technologies in terms of predictive analytics to identify when people are going to relapse before it happens in order to prevent that. So I'm very excited to participate in this panel and to hear what the gentlemen have to say. Thanks.
Great. Judd?
Great. I'm Judson Brewer. I'm an addiction psychiatrist, and my day job is the director of research at the Center for Mindfulness at UMASS Medical School. I founded Claritas MindSciences back in 2012 when Yale patented a bunch of my neuroscience work. And we really launched into really taking our evidence-based therapeutics that we had been delivering live and had clinical efficacy for to see how we could deliver these in the digital age. So we've created two products as the flag or the start of our therapeutic platform. One for smoking cessation called Craving to Quit. Another called Eat Right Now, which tackles, if you think of eating as in the addictive spectrum, with stress eating, binge eating, that type of thing. We've just finished data collection for a number of clinical trials for our smoking program and for the first clinical trial for our Eat Right Now program this summer. And both of those, if you're interested in taking a look to see how they work, they're both out. We've done soft launches with both of those. And importantly, we're really trying to bring together the theoretical understanding of how addiction works, which there's a lot out there that's really good, both in terms of behavioral mechanisms as well as neurobiologic mechanisms, but also trying to bring this together with how people learn, what the very simple learning process is. So that's how we've been focusing our work, and I'll just leave it at that for the intro.
Great. Charlie?
Yes, as Corey indicated, I'm Charlie Curie, and I'm principal with the Curie Group LLC, and have been in that position, formed the Curie Group 10 years ago. As Corey indicated, prior to that, I was administrator of the Substance Abuse and Mental Health Services Administration in the Department of Health and Human Services, and prior to that, I was Deputy Secretary for Mental Health and Substance Abuse under the Ridge Administration in Pennsylvania. And I'm also a recovering provider. I started in the field as a clinician, working in mental health and drug and alcohol centers, and then became CEO in one in Ohio and one in Pennsylvania. So I've been privileged to see service delivery from the front line, being responsible for that, as well as from a public policy and state standpoint, as well as from the federal level. The Curie Group has been focused on, most recently, we do focus on public policy issues, working with providers, states, payers, managed care organizations, technological companies, pharmaceutical companies, around public policy issues and issues around implementation of effective mental health and substance use interventions. And lately, I would say the last 5 to 6 years, a major focus on the innovative use of technologies in behavioral health and addiction, specifically bundling, if you will, medications, which have evolved greatly in the addiction area. I think everyone's aware of Suboxone, buprenorphine, of course methadone, but also you have naltrexone, which is now in a long-term injectable form called Vivitrol. And these have been significant movements over the past few years, and combining that with digital mobile technologies and yielding some excellent results. I think one of the things that I've struggled with through the years is the addiction treatment field, as well as the mental health field, has been what I consider a black box in a lot of ways. And addiction has been considered historically a relapsing disease that a person has to go through treatment on the average of 6 to 7 times before maybe it takes hold. And when it comes to the 12-step program, it has helped maybe 10% of the people that are there. Now, I'm a proponent of 12-step. I'm a proponent of how many of these programs have saved lives, so I'm not being critical, but I do feel we're at a stage, and I learned a lot in 2010 when my wife was diagnosed with cancer, went to an oncologist, and the oncologist is saying, well, if you do surgery, and if you do this radiation, this chemo, this follow-up, you have a 92% success rate. If you don't do the radiation, it's 89%, which is very quantified. And I sat there thinking, we don't talk that way in the addictions field, and we need to move that way. And I do think with the types of approaches and bundled medication with technologies, and what we're learning more and more about peer supports and networks to prevent relapse and encourage recovery rates, addiction treatment is really at the point that we are going to have treatment protocols that will yield predictable outcomes that are improved patient outcomes, improved life outcomes, as well as savings. Also, I'm a firm believer that behavioral health is the major lever for us finding healthcare costs, trying to bring those down, as well as, again, improved clinical outcomes.
Great. Charlie, I think that's a really great conversation starter. And I guess as we think about the digital landscape, I think we're in a position to be able to achieve reduced cost, more predictable outcomes, and enhanced efficacy. And really, as we think about those as the major goals, we see 2 big buckets of types of digital tools that are out there. As this panel was getting together, I think the way that we chose to classify them was as digital support, or really ways of bringing addicted patients together, and then digital therapeutics, ways of making addicted patients better. And so given that we have 2 of the world's experts around both of those topics, Chris, maybe do you want to give a brief introduction and sort of the way that you think about digital support? And then Judd, do you want to follow up on digital therapeutics?
Great.
Absolutely. So addiction is a disease of isolation. So for so long, people have struggled with the stigma, with shame. People don't talk about addiction, so people don't know that there's help out there and available. Imagine how powerful it is if you feel like you're struggling with something alone, you have no one to reach out to, and you can pull up your smartphone, open an app, and then because of the geolocation in the app, you can see that not only are you not alone, you're surrounded by individuals who are dealing with and overcoming the exact same issue that you're struggling with. And that's one of the beautiful things about connected health, is that we are removing barriers to people being able to access support. So with SoberGrid, we built the app on the knowledge that programs of peer support, like Alcoholics Anonymous, Narcotics Anonymous, other 12-step programs that incorporate peer support, are effective for many people. The challenge is that there are barriers to accessing programs like this. So they're not available at all times of day. If it's 3 in the morning, I'm in Boston and I'm struggling, I'm out of luck if my only resource is to go to a meeting. They're not available in all geographic vicinities, and they don't appeal to all people. So a 19-year-old struggling with heroin addiction is not necessarily as comfortable going to an AA meeting with 60-year-old alcoholics as they are pulling up their smartphone. And that's where the youth demographic that's disproportionately affected by opiate addiction, heroin addiction, that's where they live. They live in the mobile space. They spend so much of their time on their mobile devices. So let's reach them there. Let's give them a tool where they can find and connect with others in their demographic to receive that peer support that's so crucial. One of the challenges that we're trying to address, as Charlie mentioned, are these relapse rates, which are abysmal. So addiction is being treated acutely, but it's a chronic condition. And like any other chronic condition, diabetes, you need to give people the tools to manage their condition. So we can't just send them to treatment and send them on their way and say good luck, because the relapse rates currently approach 90% within a year after leaving treatment. So what we have the opportunity to do with apps, with other digital support tools, is to extend that continuum of care, to give people the support they need when they need it in order to help them to prevent relapse. And again, especially when we're dealing with opiates, that's a life or death matter. Your next relapse may very well be your last. So right now, the landscape, as I see it, there are web-based portals and discussion groups. There are apps like Sober Grid that are building communities, as well as apps that are more clinical focused, such as HS. And so there's a variety of tools, which is great, and we're seeing what's effective right now, but the landscape is still very fragmented. So there are many different people tackling this issue.
And maybe I can just hop in terms of pairing those types of communities with the digital therapeutics. If we want to think of digital therapeutics just broadly as delivering a therapy through any digital means, importantly, we should distinguish this from like the health and wellness space. So we're taking, take opioid addiction as a pain point. So somebody has an addiction, or somebody's smoking, or somebody's stress eating. We're taking those and providing targeted digital therapeutics in that manner. So I think it's important to distinguish this from the health and wellness and really see this in the therapeutic space. Now, if we want to think of the overview of strategies, we've already heard a little bit about the leading strategies in the space are cognitive behavioral therapy. There's relapse prevention that was kind of started by Alan Marlatt, and then there, to a lesser degree, contingency management, where there are types of rewards that are given for abstinence, for example. So we can think of this broadly as a cognitive domain. CBT has the best evidence behind it. It's kind of the NIDA gold standard treatment, and we see this delivered both in person as well as increasingly online. So we can think of that as kind of leading the space. Now, where there are deficiencies, and I think this is where the space is quickly starting to do clinical research to figure out how this works, is how these can be delivered through digital means efficaciously. And importantly, coming back to making sure that they're following the principles behind cognitive behavioral therapy, for example, and delivering those efficaciously. And importantly, that those are linked to outcomes, so that we can see when this is delivered this way, it leads to this. So we can start to talk about the numbers that Charlie was talking about. So this is where we're kind of the space is being led. Now, interestingly, I don't know if any of you saw the Tesla announcement where they're saying they're going to equip all of their cars in the future with autonomous, self-driving capacity, but they're not going to roll it out until they figure out that it works. I think we can think of the digital space in a similar way, where there are an increasing number of wearables, of ways that we can monitor not only physiology, but geolocation, as well as somebody's data, to see if we can find patterns. The critical piece to link all of this stuff up is to figure out how these, find the aspects of this technology that actually is most efficacious as compared to just trying to bundle as much stuff as possible just because there is a phone available. So we're starting to see where people are being thoughtful about bringing specific aspects of technology into a therapeutic. And where I get really excited is when we see how that fits beautifully with the behavior and neurobiologic mechanism. So I'll just mention some of the main players, and I think some of them have already been mentioned, so I won't go into the details here, but HS has been around for a while, and Charlie's going to talk about that a bit. Corey's group has started to develop some very interesting therapeutics. One of them is called Reset. And I think more and more we're going to see how we can think of the cognitive aspects of things can start to be paired even with medications. Now in the addiction space, unfortunately, there aren't tons of great medications, but we're starting to see the emergence of good ones and some that have been around a long time, for example, with opioid dependence. In my clinic, I run a buprenorphine clinic, and we find that buprenorphine is one of the evidence-based therapies I think that's going to really help us move into the future. It has fewer regulatory hurdles, fewer location hurdles than things like methadone. And so we're going to start to see, as new therapeutics emerge, both from the cognitive domain as well as the medication domain, how those all fit together. And I'll just mention one other approach that's now emerging that I have the most experience with, which is mindfulness training. For those of you that had the chance to see Zoe's talk this morning, she talked about this System 1 and System 2 in the brain, where we've got this impulsive brain, which is the habit-based one, which is what relapse comes from, and then this thinking part of the brain that helps us be it's kind of effortful, but we can think through a problem and fix it. Where we get to really dig into this is to ask, when we look at the neurobiologic mechanisms, we can start to understand, when people are vulnerable to relapse, which aspect of treatment is going to help bridge that gap. So for example, with cognitive behavioral therapy, again, gold standard, but there have been some questions around when people get really stressed out, how efficacious does that end up being, because the prefrontal cortex tends to go offline, kind of blocking people from accessing that really critical information. So with digital therapeutics, we're starting to see information-based treatment, where you can help train somebody to be there, to have the cognitive skills. Importantly, I think we're going to have to see how that works in real life when people are struggling, especially around relapse, which typically comes after a stressful situation or something like that. Mindfulness is slightly different, as it taps into this System 1 itself instead of relying on System 2, focusing on the actual learning process itself. So this trigger behavior reward aspect, where we can really help people see clearly what the rewards that they're getting, so that they, in an embodied fashion, really recalibrate what they're actually getting from the reward. And we're seeing some interesting results around that, in the sense that they don't have to rely on their thinking part of the brain, but can actually tap into, if you want to think of it, their bodily wisdom, to really see what they're actually getting from their behavior. And we're seeing some good results from that, both in the smoking space, but also more recently in the eating space. And mechanistically, we're starting to see even the decoupling between craving, which leads to very automated behavior, and the actual behaviors themselves, such as stress eating or smoking.
Great. And I might briefly steer a bit. I think that's been a great landscape overview of the modalities employed and some of the technological-based solutions here. I guess I would just like to assert that there's dogma that these things work. I think the data is great, and so frankly, I think the conversation for today is not, do these work or do they not work? Would be happy to refer you to the literature. There's great data, and we can talk about it here. I think the elephant in the room is, what are the barriers to implementing these things, and why aren't patients who need these technologies able to access them easily today, and why isn't the healthcare system able to pay for them? And so maybe, Charlie, with that bit of lead-in, can you talk a little bit about some of the successful cases, some of the unsuccessful cases, and some of the barriers that you're seeing out in the world?
Sure. I'm happy to. I'm struck when I listen to Chris and Judd, and of course Corey and I've had many conversations about how we're finally at a point of treating every aspect of the addictive disorder, and technology is empowering that. We've known for years that there's a emotional, mental, social connectedness issues around addiction, the isolation, for example. We also know that there's spiritual, and a lot of the traditional treatments have addressed those to some extent, a large extent, but we also know that there's a biological basis. Mm-hmm. And that's where the medications combined with the technologies, mobile and digital technologies, really give us a great opportunity. And also a little bit of part of the context, In 2012, out of the 8.6 million inpatient stays throughout the country, 1/3 of them had a mental health or substance use disorder involved with it. So again, thinking of leverage, that's very important. And so it's also very important as we look at how do we bring this to scale and what are the barriers. I mean, some of the successes, a couple of examples I'd point to, and one is why I got very enthused about this arena was working with a pilot program of a SAMHSA grant to a provider that was a client of mine in upstate New York that worked with the VA. And the N in the pilot, 46 veterans who, to qualify, had to have 3 hospitalizations in the prior 18 months due to their alcohol abuse or alcohol dependence. So these were individuals that were chronically relapsing. It goes to the chronicity that Judd has discussed. And what we found in this process, the approach that was being used was to use the medication Vivitrol, injectable extended release naltrexone, along with HS. And what I might say about HS, it's addiction comprehensive health evaluation systems. And it was developed out of the University of Wisconsin by Dr. David Gustafson. It's probably been one of the oldest around in terms of this area and arena. And some of the features, which, there's some of the features, such as Chris described with Sober Grid. There's the connectedness with support groups, immediate connectedness with the clinician if you're in trouble. There's GPS. I liked what Chris described about his, is that the GPS feature lets you know who's around, which I think is just tremendous innovation. I love how things are just getting better and better. What HS has was GPS that you could put in your old watering holes where you used to get yourself in trouble, and put that in with your clinician. If you came within 100 yards, an alarm would go off on your smartphone, not only letting you know that you're in danger, but also it would also let your support system know, your sponsor, your peer support, your spouse, and people begin calling, hey, how's it going? I see where you're at, are you doing okay? And I also agree with Chris's point that I think young people are going to use the smartphones to their benefit in treatment interventions. We were wondering in this pilot if some of the folks in their 60s in particular, Vietnam vets and others would find this useful, because there were several in that generation. I have a vivid memory of one of the individuals holding up the smartphone saying, this has saved my life. And he said, I was resistant to the idea, but it really has been working. What we found in that study is after the first year of implementation of this bundled approach of medication with smartphone, mobile digital technology of HS, 70 to 75% decrease in rehospitalization rate. And then 3 years out, it was evaluated, it was still around a 60% decrease in rehospitalization rate. To Corey's point, this works. Another example I point to that's currently showing some great results is Central Kansas Foundation. Les Sperling is the CEO. He has developed a protocol, as I described earlier, which includes screening and brief intervention in emergency rooms. He's actually a relatively small drug and alcohol provider. It shows what you can leverage. He has 65 employees in 7 locations, but he's been able to develop a relationship with hospital and health systems in Kansas, and drastically reducing, in one case by 85%, the number of inpatient stays as well as ED use. Because he has people stationed appropriately in the acute areas and in the emergency departments. He has peers and supports also in the inpatient areas. But some of the key is doing screening and brief intervention, which is an evidence-based practice if you're familiar with SBI. Actually, that's one thing that has its own code. I'll talk in a moment about that being a barrier, is having the right codes that you can bill Medicaid and other payers for. And then based on the screening, determine, can this person benefit from a brief intervention, or is it more serious and do they need treatment? Making sure there's a clear pathway immediately to either medical or non-medical detox, and from there a clear pathway to the appropriate treatment, whether it's residential, intensive outpatient, or outpatient, and an assessment for medication. Is Suboxone in order, for example? Is Vivitrol in order? But immediately have them linked up with HS and become part of that, and using peer support, both face-to-face, but then them being part of that ongoing 24/7 connectedness. So again, some of the results I mentioned, 68% decrease among uninsured in terms of the number of ED visits, 54% increase among the Medicaid eligible. And we're talking ends of, for example, of the uninsured, they used to have about 1,200 cases in the course of a year, and that's down to 384. I think you can see the impact that has in a very positive way of health systems as well as individuals having a better quality of life. Also, the ED visits of patients who engaged in services, we saw a decrease in those who didn't complete services. So we're seeing people stay in service longer, which is a critical factor in terms of success. 497 before the Central Kansas Foundation program was implemented, down to 182 during the year after it was implemented, so a 63% decrease. So again, these are very dramatic results. Now, what are some of the barriers that get in the way of us being able to implement these things? Well, one thing, lack of success. The one lack of success I would mention, and it will be a state that will remain unnamed, but I was working with a particular state, with their state director of drug and alcohol as well as their Medicaid authority. And this shows an example of the resistance to the use of medication in the drug and alcohol field. When Vivitrol first came out, traditional drug and alcohol providers historically were against use of any chemicals. And it was primarily 12-step and psychosocial types of rehab approaches. So there was a resistance to using medication. There was a suspiciousness of using smartphone technology as well, like how would this work? And for a period of time, this state director, even after we oriented him to how the medication really works, and in most cases, like for example with Vivitrol, FDA indicates you cannot just, and Alkermes, the company that produces it, fully agrees with this, you just don't give a shot that lasts for a month and the person's going to be okay. It needs to be wrapped around appropriate treatment based on a treatment plan, and smartphone technology can be a piece of that, or a major part of that ongoing. So again, a lot of opportunity here. But I remember after about the third time of presenting this to the individual, he said, I just don't see how a shot cures addiction. And he just couldn't kind of get through that. So that's been a barrier. So one of the major barriers that I would outline is what I call ideological-based treatment versus evidence-based treatment. If we really are committed to the evidence of what works, it opens up these horizons of treating holistically people with addictions. If we want to stay in 1970 mode, again, I'm not being critical in that we did what we could back in the 70s, 80s, and 90s in terms of what was available. But we know more of what works now. And so in addressing these barriers, we need to learn how do we do what we know. That's always the challenge in front of us, is doing what we know. Also, I would say that some of what's gotten in the way of implementation includes lack of reciprocity for medical licenses that prohibits some out-of-state practitioners in certain states to do such things as telemedicine, as well as it has implications for other forms of technology. Individual payer policies vary greatly across the country and have not kept pace with practice and are inconsistent. So we're in education mode in terms of why many of these interventions should be paid for and accepted. State Medicaid authorities are facing major budget crunches, and so they're not necessarily inclined to open up more codes that are available to reimburse. And pharmacies also have refused to fill prescriptions written by telemedicine doctors, for example. Again, I'm mentioning telemedicine here, but there's quite a relationship there between telemedicine and the expansion of technology. So we need to address this issue of understanding how codes can be implemented. A couple pathways there. SAMHSA, where I used to be the administrator, has a science to service mission. Bring the science to the frontline services. NIH has a research mission in terms of determining the science and what the science works. It's important to keep in mind then, I think for the field, we need to have strong relationships with both NIH, including NIDA, the National Institute for Drug Abuse, NIAAA, the National Institute for Alcohol Abuse and Alcoholism, and NIMH, the National Institute for Mental Health, to foster the research, to continue to demonstrate this, but then also with SAMHSA to help look at how we can accelerate the process of bringing the science to the front lines. Typically, it's 17 years from a scientific discovery until something becomes common practice. I think we can accelerate that in this day and age of these technologies where we're seeing these very dramatic results, and I think we need to be focused on that. SAMHSA, we need to work with them as they look at developing treatment guidelines that inform the field. They have some very good ones around medication-assisted treatment that have been helpful. I think looking at how we can look at these bundled approaches. Also, there's NREP, the National Registry of Evidence-Based Programs and Practices. And there you bring your results of your clinical trials, and if it reaches the evidence-based level, it comes on the registry. Then you can begin to use that, and CMS pays attention to that as you begin to work then with CMS and then the state Medicaid authorities. But it's going to need to be a concerted effort. But again, we also need to always be mindful of the resistance of the field and the providers. I think one of the solutions to the provider issue is reaching out to primary care with integrated approaches, because I think they're more motivated even than the traditional drug and alcohol providers because of the impact they're seeing. So I think there's many pathways and ways we can address this.
Great. Thanks, Charlie. So it looks like we have a question here on the right-hand side of the stage, and for other people that have questions, please feel free to filter to the front.
Okay, thank you. So I look at the addiction issue from a very interesting patient population. I live in Cincinnati, Ohio, where we had 174 heroin overdose deaths within a 6-day period. And then that is also matched with the fact that our poverty rates are double the national average, with almost 50% of our children living in poverty. And so we have things like smartphone apps where, you know, we do have 98% mobile phone adoption, but only about 56% smartphone adoption. So are there other options that are available, like text messaging programs or, you know, responsive web apps that might be, you know, for people that are maybe using phones as kind of Wi-Fi shells or things like that that might be available? And how would you work with using digital technology in such a situation?
That's a great question. Anybody want to address?
Sure. So that's a really interesting question. I mean, my focus has been on leveraging the smartphone technology, but the idea of SMS-based intervention or giving people the ability to reach out for help even if they don't have smartphones. Certainly there are web-based resources and communities, but as to how responsive and active they are, you're much more apt to have really responsive and engaged communities on, you know, a mobile device versus a web platform. It might not be as continually 24/7 feedback input. So I'm sorry I can't give a clearer.
Well, I think clearly you pointed out the where it's not as advantageous as a mobile phone, but clearly there are web portals available. HS you can connect with online. I think in Reset you have that ability as well with Pear Therapeutics. I know two others. My Strength is another online and mobile digital CBT, cognitive behavioral health treatment. That has great content as well as great connectedness, and does have an addiction platform. You can engage that through a web portal or mobile. Cobalt with Magellan Health Services, same thing. So I think all the ones I'm aware of have the ability to access, but again, it doesn't have the 24/7 connectedness, which is very advantageous, especially when it comes to peer support availability.
I think it's interesting in our experience, granted we've seen lots of barriers. One of the barriers that hasn't seemed to be an issue is this issue of smartphone penetration and smartphone availability. And just to lend a little bit of data to that, our program that sits after Reset is a program called Thrive to treat schizophrenia, and these are sick patients. And in a pilot study that we just published in collaboration with Dror Ben-Ziv at Dartmouth University, patients were using their smartphones. They were engaged with Thrive rather, multiple times per day over the course of a 6-month longitudinal study. really in a surprising fashion. I know the purpose of the panel today is not to talk about other digital therapies and mental health disorders, but I think of all of the barriers that we see, thankfully, this issue of smartphone penetration and smartphone usage is probably not one of the bigger ones. That said, I think it's really useful to just acknowledge that this entire space is in double jeopardy, if you will. So I think historically, there are lots of reasons to avoid payment for addiction care services. And furthermore, there are lots of reasons to avoid paying for technology. I think there's a preconceived bias that technology should be cheap or free, and Apple should take 30% of that. And that's just flatly not the business model that it takes to generate the clinical evidence to get to implementation. So I see that we have another question here to the right. Please.
Yeah. So I think one theme that comes out of the things that you've said so far is there seems to be a lot of knowledge about what works. It may not be perfect, but it's out there. And yet, my impression from what you all have said and what I know about the field is this field of digital interventions and addiction is we're in the very, very early stages. Mm-hmm. And so just for all the panelists, where do you think we're going to be in 3 to 5 years? And what do you think are going to be the things that are most likely to come out of this, given the knowledge, but also the barriers? Let's project out for 3 to 5 years.
Yeah, absolutely. So I think first off, what's going to drive adoption, or one of the things that's going to drive adoption, is the need for treatment providers to provide outcomes data to payers. And right now, they don't have a very good way of doing that. They don't necessarily have a way to maintain contact with their alumni, or if they do, the communication is unilateral. So by having a tool with which their former patients are engaged, after they discharge from treatment, that gives them the ability to collect data that they will probably have to be providing to payers in the near future. They'll also have to use that data to look at how they can improve the efficacy of their programs. So that's one thought in terms of adoption. And then in terms of where the technology is headed, at least for what we're doing with SoberGrid, I know Judd had mentioned the 2 parts of the brain, and you get to nip it in the bud before you reach that habit-forming part. So we're really looking to incorporate predictive modeling into the app. We have this wealth of data because we're also a social network, and people are posting about their sober lifestyle, and they're carrying their mobile device with them everywhere they go. So we have all this data, and we also have data indicating when people relapse. So we can create models to say, this person is in jeopardy of relapse, we need to intervene, and to deliver those automated, just-in-time, adaptive interventions before people relapse to really improve outcomes.
Yeah, I'll just add to that, I think we can take, the nice thing about mobile apps is that you can really collect data from just about every click, literally. And so what we can take those data and develop I think what we're going to see is one of our programmers said this great thing to me. He said, maximize the amount of work not done. And the idea there is, don't take a kitchen sink approach, which we've seen a lot of cognitive therapies have been developed through a kitchen sink approach, and there have been not enough dismantling studies to show the really critical aspects. So I think we can take the data sets that we can now start to develop and not only figure out what's going to be best for any one person at any one time, so we can start to really personalize this, but we can also pull out the elements that might not be as helpful as the other elements so that they're able to shine. So we'll see this both with the strategy development and refinement, but we'll see this also with the digital aspects of the therapy itself. So instead of giving somebody 12 different options of geolocation, this, it'll say, for you, this is the best thing right now.
I think along those lines, is looking out 5 years, I think we will be seeing more of the adoption of treatment protocols that are yielding those predictable outcomes for addictions. And I'm convinced it's going to include screening, brief intervention, medication, assisted treatment bundled with these technologies, mobile and digital technologies. And I think as more ACO approaches occur, shared savings, I think that's going to help overcome the payment issue, because I think if we continue to see these types of outcomes, and from a monetary perspective, the savings are occurring as addiction treatment becomes more predictable. Mainstream medicine is going to want to embrace it and become part of a health system. Payers are going to want to embrace these approaches and see them happening on a more regular basis. And I think it's good news for Pear and for Sober Grid, for what everyone's doing here. I think the field is turning the corner, accepting this more. And again, I think medical systems and players and ACOs are going to be very motivated to do it. So I think we're going to be in a significantly different place 5 years from now, in which these approaches will be accepted and more routine.
I think just to piggyback very briefly on Charlie's comments, I think in 3 years we'll see FDA-approved digital therapies, and if we have anything to say about it, we hope that it'll be next year. We'll see reimbursement for those FDA-approved digital therapies via unique new drug codes and UDI codes and a set of CPT codes that sit on the back end for clinician engagement. And I think when you look at treatment guidelines, digital will become first line. Yeah. There's sufficient evidence. I think what we're really struggling with is putting in place a means to pay for things that we know work. Yeah. And I think that's all set to come online in the next 3 years.
And another barrier that I failed to mention earlier is confidentiality. I mean, obviously these things need to be HIPAA compliant, number one, but in the drug and alcohol field, we have the CFR 42 regs, which were put in place years ago to protect people who were being treated for addiction, so it wouldn't be held against them. I mean, it's almost like that's in a super secure vault compared to the HIPAA requirements. And so we're going to have to think of ways of addressing that when it comes, as addiction treatment becomes part of mainstream medicine and needs to be a part of a person's holistic approach. We don't want that to be a barrier. So I know the field's embarking and thinking through how to keep people protected, but yet at the same time it not be a barrier to using the technologies.
Great. So I see that we're running short on time. I think we have one more question, and just in the service of time, feel free to direct it at anyone on the stage.
So first, thank you so much for the work you're doing. I lost 2 sisters to drug addiction, and I just think what you're doing is so incredibly important. A lot of the discussion has really focused around curative programs. Do you have any? Are you seeing anything in the space around preventative measures for younger people who are at high risk, given their family or social circumstances?
Judd, I'm just going to go for it.
I think that's a great question, and I'm just searching my brain to see. To me, that is well, first off, I'm not an adolescent psychiatrist, so I may be missing something, but I'm not thinking of anything in particular where somebody has really tackled that head on with regard to addictions in particular. So the family, improving family systems, finding where youth are at risk, finding genetic predispositions where somebody might be at risk. I have not seen much in this field. It really seems wide open.
I think some of the hope is around, again, screening and brief intervention. We've seen this work, especially with the adult population. There's more studies being done around the adolescent population, that if an adolescent who's at risk due to underage drinking and alcohol abuse comes to the primary care setting or the ED, we're seeing SBI being implemented on college campuses in a preventative mode as well. It's educating a person at the time they've hit a crisis because of their drinking. And they may not have a full-blown dependence, but the evidence has been showing us that if you educate them at that critical moment of a learning opportunity, it does change their behavior. And we're seeing that work for adolescents. So I think more work in the arena of screening and brief intervention, or SBIRT, screening, brief intervention, referral to treatment, being available around those child-serving agencies and adolescent agencies and in ERs in general will be beneficial.
One final thought, just what I do see coming down the pipeline is, I think I mentioned, we're looking at incorporating machine learning so that we're able to really analyze the language, the tone, the behaviors within a social network to predict when people are headed towards relapse. I know there's work being done looking at Facebook, Twitter, other social networks, analyzing the language, the tone, the other factors there to identify who's vulnerable to head down the path of substance abuse. So I think that's one area that's still developing.
Great. So a sure sign of a great conversation is going overtime. We've got the flashing red light here in front of us. Just wanted to thank the panel in particular and also thank the audience for spending the hour with us.